Hello people, in this video we want to look at otosclerosis or OtoSpongiosis. We want to look at the signs, differential diagnosis, treatment, in that mainly stapedectomy we want to look at. Till now in the previous video we have already looked at what otosclerosis is. We have looked at the etiology, pathology, types and symptoms. Do you remember? So we saw what otosclerosis is. It is a disease of the bony labyrinth. Basically the enchondral layer of the bony aortic capsule is replaced with spongy bone. So there can be stapes fixation or conductive deafness. It's a bilateral condition. Here you can see how there is spongy bone around this stapes footplate, right? So it's a disease of the bony labyrinth. So we saw that the aortic capsule itself has three layers: endosteal, enchondral and periosteal. The enchondral is replaced with what? The spongy bone. So we saw why it happens. Basically, they don't know why it happens, or anatomical basis, some specific spaces called the fistula antefenestrum, right, which is lying in front of the oval window. This area is more prone to such changes. Okay. Hereditary, it is an autosomal dominant trait. Whites are affected more, and the females are affected more. Remember, 30 years pregnancy, and even in menopause it can happen. Okay, so this is the etiology. Some more etiology. We saw that van der Hoeve syndrome. These people can have osteogenesis imperfecta, that is fractures, blue sclera and even otosclerosis. These three together, triad of van der Hoeve syndrome. Even if people have measles, then they can have this problem. All this we have looked at in the previous video. We're just taking a review. Pathology, you will see gross that there is otosclerotic lesion which appears chalky white, grayish, yellow. You can see that here. Microscopically, you saw that you will see the enchondral layer is replaced with spongy bone. It will have osteoclast, osteoblast, etc. And blue color the cement substance which is called as blue mantles. Okay. Then what we saw types of otosclerosis. There is stapedial type, cochlear type and histologic type. In stapedial, again, there are other types like anterior focus, posterior focus, circumferential, then biscuit and obliterative. Okay. Then what we saw the symptoms of otospongiosis. They will be hearing loss. Hearing loss will be conductive hearing loss. It will be bilateral condition. Paracusis will see, that is, the person can hear better in noisy environment. They can have tinnitus. Especially if it is a cochlear type of otosclerosis or in active lesions, they can have tinnitus. Vertigo is very less. Speech, remember, monotonous speech. Okay. So recap of previous video done. Now what will we continue with? Signs. Okay. So now symptoms are over. Signs. So signs, basically you will see that the tympanic membrane is normal and mobile. Sometimes there may be a reddish hue on the promontory which you can see through the tympanic membrane. So this reddish hue is because of increased vascularity. It indicates active focus. This is called as a Schwartze sign. So the tympanic membrane, through that you will see the promontory. It will be little red. That will indicate more vascularity. Vascularity indicates that it's an active focus. This is called as Schwartze sign. Eustachian tube will be normal, guys. Tuning fork test, what will you see? This person has conductive hearing loss, right? So there will be bone conduction more than air conduction. Air conduction is less because there is no transmission of the sound. So you can understand, because the transmission, here there is sclerosis, the transmission is not happening to your inner ear, right? So what will happen? There will be conductive hearing loss. So bone conduction will become more than air conduction. So rinnes will be negative. What will happen to Weber? Weber will be lateralized to ear which has more conductive loss, whichever has more conductive loss. So to that ear, the bone conduction will take the sound, because air conduction is blocked, right? So you should understand, it will try to go via the bone. So wherever there is a more air conduction loss, to that the bone conduction will try to take it. So Weber test will be lateralized. Absolute bone conduction may be normal. Pure tone audiometry, when you see, what will happen, you will see that there is air conduction loss, right? So you can see this is the pure tone audiometry. What will you see here? Air conduction has totally dipped, right? Everything has come down in air conduction, right? There is a, this is the bone conduction. Bone conduction has specific frequencies drop. Like there are drops, but at 2000 it is the maximum drop. That is called as the Carhart's notch. Carhart's notch or Carhart's notch. This is here. At 2000 Hertz, whatever drop you're seeing, that is the Carhart's notch or Carhart's notch. The air conduction has completely dipped. You can see this. So there is a bone, air-bone gap also. So this is your indicating what? Your conductive hearing loss. Mainly it is a conductive hearing loss. A little sensory neural also can be there. Why at 2000 Hertz in bone conduction there is a dip? Because the ossicular resonance is at that level. Okay. Then when you do tympanometry, what will you see? You remember tympanometry. The normal curve is which one? A is the normal curve. This is what you and me will have. But a person with otosclerosis, because of the stapes fixation, because of the fixed stapes, because of stiffness, you will get a smaller curve. Okay, this is small curve, AS, or otosclerosis or stapes fixation, like that you can remember. It's a smaller curve, right? One more sign, you will see stapedial reflex is absent, okay, because stapes is fixed. Now let us look at the differential diagnosis, guys. So we are done with the signs, right? Signs we are done with. Signs, what and all did you see? Schwartze sign on tympanic membrane, negative Rinne's test, Weber test is lateralized to the ear which has more conductive loss, ABC is normal. Puton audiometry, you saw AB gap, Carhart's notch in bone conduction, that is at 2000 Hertz. AS curve you saw in tympanogram, stapedial reflex is absent. These are the signs you saw. Now we are moving on to differential diagnosis. In differential diagnosis, what should you differentiate this condition from? Yeah, here. So you should differentiate this from other causes of conductive deafness, obviously. So other causes of conductive deafness will be what? Serous otitis media, adhesive otitis media. The tympanic membrane itself became hard, tympanosclerosis. The malleus is affected actually. The fixation of the head of malleus. Instead of this, what are you talking about? Instead of stapes, instead of the bony labyrinth, they seem to be talking about the middle ear condition here, isn't it? Ossicular discontinuity, again a middle ear condition where there can be discontinuity between these ossicles, that is malleus, incus and stapes. So between these bones itself there is discontinuity which can lead to conductive hearing loss. You should be able to differentiate it from that. Congenitally a person's stapes may be fixed. Probably there is no spongiosis or something, right? So you'll have to differentiate from all those conditions. So this is these are the differential diagnosis for otosclerosis. So did you get it, guys? We have finished the differential diagnosis. Can you name a few things? Serous otitis media, adhesive otitis media, then the ossicular chain is discontinued, or the malleus head has some fixation, the stapes is congenitally fixed, or there can be tympanic membrane sclerosis, right? So how many differential we gave? 6. Okay. So let's move on to treatment. Guys, we are moving on to treatment. Is it fine? So this is the last part of the otosclerosis video, treatment. In treatment, medically what you have, medically you can give sodium fluoride that will try to hasten the maturity of active focus. That sounds actually scary, right? Hasten the maturity of active focus. But anyways, this will arrest further cochlear loss. So, but then this is controversial, looks like. What are they giving, guys? Sodium what? Fluoride. Remember, fluoride. Okay, then surgical what you can do is stapedectomy or stapedectomy. Stapedectomy is they will make a hole in the stapes footplate. Okay, and stapedectomy, they will remove a portion of the footplate. But anyways, they are removing the superstructure of stapes anyways. Okay, in both of these stapes superstructure they are removing. Okay, and then they will place a prosthesis. So you can see here how they have removed stapes, which was like this earlier, right? Something like this, the stapes was. This is your stapes footplate, right? So they have removed the superstructure of stapes. In the footplate, they have made a hole and they have kept a prosthesis here. See, like this, which is hanging on to what? The incus. So whenever the tympanic membrane moves, malleus moves, incus moves, and now this prosthesis or piston will move this oval window. What is there here? Oval window, right? Okay. So this is the surgery they are talking about. But then there is another option, hearing aid. Because it's conductive deafness, they seem to be talking about hearing aid. This is the stapedectomy surgery you can see here, or stapedectomy. They are removing the stapes superstructure, right? And they are putting the piston, Teflon piston. There are 3 types of piston, guys. You have the Teflon piston, platinum Teflon piston, and titanium Teflon piston. Teflon piston is common, you see here. Only some part of it, platinum or titanium, is different. Okay. So now what we have to do is, you have understood the treatment, right? In treatment, what and all did you see, guys? You saw medical, that's sodium fluoride. Then you saw surgical, stapedectomy, and then you saw hearing aids. The stapedectomy or stapedectomy details we will go into. Okay, we will see what steps of the surgery are. Okay. Let's do one thing. Let's look at the steps of stapedectomy, contraindications, complications, everything we look at. So take a deep breath, guys. And let's look at the steps of stapedectomy. Okay. So basically look at this. They're doing this under local anesthesia. They will take a meatal incision. They'll elevate the tympanomeatal flap. They will expose the stapes area. They will cut the stapes tendon. Okay. And then they'll remove the stapes superstructure. They will create a hole in the stapes footplate, and they will place this piston and they will reposition the flap back. Did you understand anything at all? Look at this photo here. So this is your tympanic membrane. They are creating a tympanomeatal flap, right? They are going to raise it. They are reflecting it forward. So what can they see now? They can see this area where you can see what and all. You can see the, looks like this is your stapedial tendon. This is the pyramid looks like. And then here you have the chorda tympani nerve. Here you have the facial canal which has the facial nerve. And then you are able to see the stapes. So what they are going to do now, they are going to cut this stapedial tendon. You can see here they have cut the stapedial tendon. Right, stapedial tendon is cut, and even stapes superstructure is here. See, they have removed it from these two. From where it was, it has been cut out. The stapes suprastructure. Okay. Then what they are doing? They are making a fenestra, a small fenestra made in the footplate, and a Teflon piston is inserted. So it is where it is sitting on the Teflon piston incus, and it is going into the stapes footplate in that fenestra. So did you understand that all, guys? Did it make sense? The steps of stapedectomy, can you say now? What you will do? Tympanomeatal flap you will raise, then you will look into this area which has this stapes and all that. You will cut the stapes tendon, and then you will remove this stapes suprastructure. In that footplate you will make a fenestra, then you will put this piston in such a way that it is attached to the incus. Great. So we are done with the steps of stapedectomy. Now let us look at selection of patient for this. How will you choose a person for this? Which patient is right for the surgery? Basically, people who have really bad things. Hearing threshold of air conduction should be 30 decibel or worse. That means you should speak at high intensity for them or something. They should be socially handicapped kind of a thing. Then only you'll do this kind of surgery. Airborne gap should be at least 15 decibels. That means it should be more than that, right? Rinne negative. Rinne negative for these two tuning forks means what? At least the airborne gap should be more than certain amount. Speech discrimination score should be 60% or more. So basically everything should be more. More hearing loss they should have. Then only you do this kind of surgery. Okay. What surgery? Stapedectomy. So you will remove the stapes suprastructure. You will make a hole in the footplate. You will put a piston. Okay. That is stepedotomy kind of a thing you can say. Okay. For whom you won't do the surgery. Basically, they have only hearing in this only ear. The other ear is not working. Then you don't do this type of surgery, okay? If they have Meniere's disease and all, don't do the surgery. Young children don't do the surgery. Their prostheses and all can get displaced. If people are professional athletes, divers, air travelers, frequent air travelers, don't do the surgery because the pressure change and all may affect, okay? Then it may cause vertigo in them. People who work in noisy environments, they might anyways have sensory neural hearing loss, right? So in those people also you don't do. Then if people have other problems in their ears like otitis externa, tympanic membrane perforation, exostosis, in such people also first fix the problem that they have. Don't do the surgery first, okay? So you understood the contraindications. What are the contraindications? Only hearing ear, young children, divers, air travelers, pregnant females. If they have Meniere's, don't do. If they have other problems, treat those problems first. Finally, we reached complications. What will happen if you do the stapedectomy? Basically, you can tear the tympanomeatal flap, perforate tympanic membrane. You can injure the chorda tympani nerve. You saw the chorda tympani nerve, right? How close it is. Facial nerve also can get injured. You saw the positions when you open the tympanomeatal flap. Incus can get dislocated. You know, you're handling the incus, right? You're removing the stapes. You're breaking the suprastructure of the stapes and removing it. You may dislocate the incus. Looks like vertigo people can have. They can have a perilimb fistula granuloma. They can land up with conductive loss. You were trying to fix this only, right? And they'll land up with conductive loss. Why will you think they'll land up with conductive loss? Because you put a short prosthesis or you put a loose prosthesis. The piston, whatever you're putting, no, you put a short one or you put it loose or this prosthesis got displaced or the incus itself got eroded later in life kind of thing. Sensory neural hearing loss, why will they have? Because some post-operative trauma happened to your labyrinthitis, perilimb fistula, all that, and then dead ear. Finally, they are saying that is a complication. Okay. the ear is dead ear, totally dead. Do you think dead ear and deaf ear are both same? Deaf ear we can understand. What is dead ear? Single-sided deafness is when a person has lost all the hearing in one ear. And dead ear. So what is deaf ear then? Anyways, people, looks like other than the stapedectomy, some old things they have mentioning. Stapes mobilization, they are not doing it nowadays. Then some Lempert fenestration operation also is outdated, they are saying. So let's not bother about those. What have we looked at in this video? In this video, we looked at signs, differential diagnosis, treatment. Let's take a recap. Signs, what did you see? Schwartze sign, rinne negative, where bone conduction is more, Weber lateralized to the ear with more conductive loss. Absolute bone conduction is normal. Then in Putron audiometry, you will see AB gap and Carhart notch in bone conduction at 2000 Hertz. Then you saw the AS curve in tympanogram, stapedial reflexes absent. Differential diagnosis, glue ear, serous otitis media, then adhesive otitis media, tympanic membrane sclerosis. Do you remember the other? Attic fixation of head of malleus, ossicular discontinuity, congenital stapes fixation. Yes. Then treatment, you saw medical is sodium fluoride, but that's controversial. Surgical, you have stapedotomy, stapedectomy with a Teflon piston, and hearing aid is also suggested. Then we saw the types of prosthesis, we saw the steps of stapedectomy, we saw the selection of patient, we saw the contraindications, and we also saw the complications. So that's all guys in this video. We have covered this topic, otosclerosis, otospongiosis. Bye bye.
Bye bye.